Hi, my name is and you're watching the video Myasthenia Gravis Clinical Characteristics. In this video, we'll be discussing the ocular signs and symptoms that patients have when they have Myasthenia Gravis. We're specifically focusing only on the ocular signs and symptoms, not on any systemic characteristics. Okay, so we'll methodically move through the variety of symptoms that the patient may have who's been diagnosed with Myasthenia Gravis. So firstly, one of the most common signs is the ptosis. Now, often this is actually the first presenting sign. So the patient will come into an ophthalmology clinic, they'll see an orthoptist and an ophthalmologist, and the ptosis is what leads to the potential diagnosis of Myasthenia Gravis. Now, the ptosis is often variable. So because we're talking about a disease that relates to fatigue, it can be better in the morning, and as the day progresses, it can be worse. Often it's bilateral and asymmetrical, and day by day this can vary as well, in the sense that sometimes the right one might be worse and other days the left one might be worse, as an example. And given again that this relates to fatigue, usually sleep will make it better. So patients will comment on the fact that when they've had a good sleep, or even if they've had an afternoon nap, when they wake up, the ptosis is better. To the right here, we have two patients with Myasthenia Gravis and ptosis. In this instance, in the above picture, we have someone who's not got any significant ptosis of the right eye, but complete ptosis of the left. And in the next example, we've got bilateral ptosis, and the right one's worse than the left. The other thing that patients with ptosis may present with is frontalis overaction. Now, frontalis overaction can be seen in the patient here to the right, where the left eye has the ptosis, and you can just see the overaction here of the frontalis. Now, this can also lead to unilateral lid retraction due to the sustained overaction of the frontalis. Some patients may also exhibit what's called the enhanced ptosis. In this instance, a patient will have bilateral ptosis, and if the eyelid is held by the examiner, and in the example here to the right, we've got a patient with bilateral ptosis, and the examiner here is holding that right lid, what will happen is that the other eye, the ptosis in the other eye will start to increase. And we can see here that these are relatively equal, the ptosis, the right and the left eye, and then when the right one is held up, the left one starts to drip further down. And it's thought to be due to the innervational drive to the lids actually decreasing due to the one being held up, and therefore resulting in the increase in the ptosis of the other eye. If you have asymmetrical bilateral ptosis, then it's always best to lift the one that is the worst or has the greatest ptosis. Another sign of Myasthenia gravis is what's called the Cogan's lid twitch. This is seen in about 50% of patients, and you can elicit it by asking your patient to look down, maintain that position for a few seconds, and then ask them to look quickly up back into primary position. And what you'll see is the lid will overshoot and return into its position. So it's a little twitch. It looks like a little twitch. If we take a look at the image to the right here, this is the patient looking into primary position, and we can see here that we've got a significant ptosis of the left eye. The patient is then asked to look into down gaze and maintain that position for a few seconds. They're then asked to look back into primary position. And here what we can see is that there is a significant overshoot of both lids, both the right and the left. This is the final resting position of the patient. So you can see that where they rest in the end is very similar to how they began. But there was a twitch between this position and this position here, such that the eyes or the lid overshoots on both sides in this instance, and then returns to its resting position or normal position. This is known as Cogan's lid twitch. Patients with Myasthenia gravis can also show levator weakness. This is when you ask a patient to maintain sustained up gaze, the ptosis will gradually get worse. So if we have a look at the position, or the patient, here to the right, they've been asked to look into upgaze, and we can see that the left ptosis is present here, but it's not too bad. And as we progress through images B, C, D, E, F, time is elapsing. And what you see is, as time elapses, the ptosis of the left eye increases. Okay, this is the levator weakness demonstrated by the patient with Myasthenia gravis. Another sign seen in patients with Myasthenia gravis is orbicularis weakness. With orbicularis weakness, patients will have issues tightly shutting their eyes, and you'll be able to easily open their eyes even when you're asking them to really tightly shut them. If we take a look at the patient to the right, this is a patient who has been asked to tightly shut their eyes. And this left eye is closed, and what you can see is that the eye doesn't look tightly shut. The patient is really unable to bury their eyelashes when closing their eyes. Okay, this is an indication of orbicularis weakness. Now, the examiner has, whilst asking the patient to tightly shut their eyes, is trying to open the eyelids. And what they're finding is that they can do this with relative ease. It's actually really not that easy to open up someone's eyelids when they're tightly resisting you and tightly trying to shut their eyes. So these signs of a patient being unable to bury their eyelashes when asked to tightly shut their eyes, where they're unable to keep their eyes shut as the examiner tries to open them, are signs of weakness of the orbicularis. The other thing that you may see, which we don't see in this particular photograph, is that with orbicularis weakness, what we can see is the peak sign, where if you ask the patient to sustain holding their eyes shut for some time, what you'll start to see is that they can no longer keep their eyes shut, and you'll start to see the opening of the palpebral fissure, which looks like they're peaking, but they're actually just not able to sustain the eyes shut. Let's now move on to ocular movements and Myasthenia gravis. Now, we know that Myasthenia gravis affects the muscles, and so it's expected that this condition can also affect the extraocular muscles, so we can see weakness of the eye muscles. If this is the case, Myasthenia gravis will mimic various eye movement disorders. It can mimic neurogenic disorders such as a third or a fourth or a sixth. It can also mimic supranuclear eye movement disorders such as eye nose or gaze palsies. Myasthenia gravis is actually known as the great mimicker because it can present, or the patient can present with what appears to be a neurogenic palsy, and later you'll find it's actually a pseudo-neurogenic palsy. There's some debate as to which eye movements or which muscles are affected earliest or more often. Some indicate the inferior rectus is commonly affected, others indicate upgaze is commonly affected, and then others again indicate the medial rectus. In any case, it's just important to think about the possibility of Myasthenia gravis when assessing a patient. Now, you should be able to differentially diagnose a true neurogenic palsy versus a pseudo-neurogenic palsy due to Myasthenia gravis. The true neurogenic palsy does not have the associated clinical signs we've been discussing regarding Myasthenia gravis, such as the ptosis, excluding, of course, a third nerve or superior division of the third nerve. But there's no Cogan's lid twitch, or there shouldn't be orbicularis weakness in most patients. We'll also see in the subsequent video, when we discuss the clinical investigations pertinent to Myasthenia gravis, that there are a series of tests that will assist you in determining that the patient has Myasthenia gravis and not a true neurogenic palsy, as an example. The other thing about these patients and their ocular movements is they're variable. So the eye movement limitations are variable, as is the diplopia associated with the eye movement disorder. So if you're assessing them and the patient is becoming worse as you're assessing them, then this is again an indicator that you're dealing with a patient with a pseudo eye movement disorder. Over to the right here, from Ansons and Davis, we have a Hess chart, or two Hess charts of the same patient, one pre-treatment and then one post-treatment. And here Hess chart before treatment depicts a patient with a pseudo-INO and fourth nerve palsy of the left eye. And we can see here the limitation of the medial rectus, and we can see in the outer field the limitation of the superior oblique. Post-treatment, we can see significant improvement of this eye movement disorder. This is typical of a patient with Myasthenia gravis. Okay, in summary, Myasthenia gravis has a number of clinical signs and symptoms that directly relate to this condition. Generally, these relate to the eyelid and to the extraocular muscles. So in relation to the eyelids, the things we can see is ptosis, frontalis overaction, enhanced ptosis, levator weakness, orbicularis weakness, and Cogan's lid twitch are what we may see with patients with Myasthenia gravis. And remember, the ptosis occurs in the majority of patients with Myasthenia gravis and is often the presenting sign. In relation to the extraocular muscles, in this instance, we'll have weakness of the extraocular muscle or muscles, and we could end up with a pseudoneurogenic palsy or a pseudo-supranuclear palsy, and the patient will experience diplopia. And again, overall, many of these symptoms, such as the ptosis or limited eye movements and diplopia, can be variable and often become worse throughout the day or with fatigue. Okay, that brings us to the conclusion of this video. Thank you for watching.